Welcome back. In this video we are going to cover Zollinger-Ellison Syndrome, also known as gastrinoma. So, gastrinoma, it happens that we have a tumor in the pancreas or in the duodenum that is secreting gastrin. This hormone that will affect the parietal cell to secrete acid. So remember, the parietal cell receives innervation from the vagus nerve, and through acetylcholine it will release proton or the acid, the H+. Also, it is responsive to histamine H2 and gastrin receptors also. In response to gastrin, it will secrete acid. However, gastrin also can stimulate endochromaffin cells to secrete histamine and stimulate the parietal cells, and hence increase acid secretion and causing low gastric pH. The symptoms are related to the acid, so we will have ulceration, multiple ulcer resistant to treatment, and it will be distal ulcers in the duodenum and the proximal jejunum. Also, we'll have diarrhea because the acid will destroy the mucosa in the duodenum and small intestine, causing the diarrhea. Also, it will inactivate lipase, causing osmotic diarrhea. 70% of the patient will suffer from diarrhea in Zollinger-Ellison. Another lab findings is that hypercalcemia, when the gastrinoma is associated with MEN1, multiple endocrine neoplasia type 1, which includes pituitary adenoma, parathyroid hyperplasia causing the hypercalcemia, and pancreatic tumors such as Zollinger-Ellison the gastrinoma, and in some cases vipomas, insulinomas, glucaconomas. We will mention them separately in the endocrine section. Now this pancreatic islet tumor helps you to locate gastrinomas. So it is located in the pancreas or in the duodenum. Usually the main mass will be there. Now the second question is it metastatic or not? We will mention this later during this lecture. Now let's review some pathophysiology. So the pancreas will secrete the gastrin. The gastrin will stimulate parietal cell, and through the endochromaffin-like cells will release H2, will stimulate the parietal cell to secrete acids. However, there are certain cells in the duodenum called the S cells, which secrete something called secretin. Now, secretin is a hormone that will shut down gastrin. So whenever we have gastrin, it will release acids, and the acid will stimulate the S cells to secrete secretin, which will inhibit gastrin. So this is important to know because we will use it as a test later on to confirm the presence of gastrinomas. Also, secretin stimulates the duodenum and the pancreas to secrete bicarbonates to counterbalance the acidity of the gastric content being secreted into the duodenum. So this is another function to secretin. Physiologically, low acid will cause high gastrin release. However, in gastrinoma, we will have high gastrin in the presence of high acid because of the autonomous secretion of gastrin. This is very important because of the paradoxical presence of both gastrin and high acid content. So whenever you are facing patient with multiple ulceration, distal to the duodenum and proximal to the jejunum, think of gastrinoma and take gastrin level. You will see high gastrin level, but make sure that the patient is off PPIs and H2 blockers, ranitidine or cimetidine, because low acid will cause natural gastrin release. Second, after you see high gastrin and the patient is off this medication, anti-acid medication, you should do the confirmatory test to confirm that you have gastrinoma. So you bring the patient and you give him secretin. The secretin will cause decrease of gastrin release. This is in normal patients. However, in Zollinger-Ellison, you will find normal or high gastrin levels despite secretin injection because of the autonomous gastrin secretion from the gastrinoma or the tumor. This is what will confirm that we have gastrinoma. Now, after the confirmation of gastrinoma, the diagnosis, we need to do imaging to decide on the treatment. If the patient has localized gastrinoma and has no metastases, then the treatment is obvious. We do a surgical resection to the tumor and we get rid of the gastrinoma, and hence we solve the problem. So if we have localized disease, then the answer is surgery to remove the tumor. However, surgery won't help in the case of metastasis. In this case, what we do is we do imaging to decide if the patient has metastasis: ultrasound, CT scan, MRI. However, these imaging modalities cannot help to rule out metastasis. So we do them. In case they are positive, they confirm that we have metastasis. So they are specific, but they lack sensitivity. They cannot rule out metastasis. Okay, so all the patients should undergo imaging to decide on the tumor, if it's localized or it is metastatic. If we are suspecting metastatic disease and the initial imaging are normal, then we do something called somatostatin scintigraphy and endoscopic ultrasound. Somatostatin scintigraphy uses somatostatin, which is the hormone that will inhibits all the body hormones. So we use it because it inhibits gastrin. We take a radionuclear tagged somatostatin and we inject the patient and see if the gastrinoma will take that somatostatin that is nuclearly tagged and see if we have metastasis using special scanner. For the endoscopic ultrasound, it is an ultrasound attached to a scope that enters the GI tract and helps us to gain imaging, and it can reach the duodenum to identify any tumor. Usually, clinicians use the combined test to locate all the metastases and determine the management of the patient. Remember, for localized disease, then the answer is surgery. For metastatic disease, the answer is to use long-term PPIs, proton pump inhibitors, which are used in higher doses and for long-term to control gastrinoma ulcerations and symptoms. In this video, just a quick review for the multiple endocrine neoplasias, men type 1, men 2A, and men 2B. Just how to differentiate between the main men, these three findings. So in men 1, we will have hypercalcemia. In men 2A, we will also have hypercalcemia. In men 2B, we won't find this. However, in men 2A, we will find high blood pressure. In men 2B, we will also find high blood pressure. And remember, in men 2A, remember 2 A's, so it contains all the letters A and B and C because it's 2 A's. So A for type A, it's B for the blood pressure, and C for the hypercalcemia. A, B, C, it's men 2A. Men 2B, because it's B alone, 2 B's, it's only blood pressure, so we will find high blood pressure. In type 1, remember 1, it's written 1, it's calcium, it's only calcium, hypercalcemia alone. So type 1, calcium, hypercalcemia. Type 2A, 2 A's, so A plus, so ABC. Type A, high blood pressure, hypercalcemia. Type 2B, B alone, blood pressure. The blood pressure because of the pheochromocytoma, and the calcium is because of the parathyroid hyperplasia. We will discuss them further in endocrinology.